Good morning. Okay. So today's topic is femoral triangle. Okay, and its clinical aspects. Mainly, we will discuss the femoral hernia. Femoral hernia is very important. Next, silence everyone. Okay, so femoral triangle, it is a triangular depression on the very front of the upper third of the thigh and below the inguinal ligament. This is the location of the femoral triangle and its apex is pointed downward. Next, see, this is the femoral triangle. Here is the base. Silence. So base is formed by the inguinal ligament and apex is formed by joining of the medial and lateral boundary. Okay. Medial boundary is formed by the medial border of the adductor longus muscle and lateral boundary is formed by the medial border of this sartorius muscle. Okay. And these two are meeting at the apex of the femoral triangle. Here, this is sartorius, here is the adductor longus. So, here these two boundaries are meeting, lateral and medial boundary and forming the apex, and this is inguinal ligament forming the base of the triangle. Okay. Next, so the femoral triangle is a hollow area in the anterior thigh and large neurovascular structures pass through this area and can be accessed relatively easily in this area. Okay, femoral artery, femoral vein, femoral nerve, all these are important structures are passing through this triangle and thus it is an area of both anatomical and clinical importance. Next. So these are the boundary. Boundary of femoral triangle is very important. You will be shown this area in your dissection also. Okay. So base of this triangle is formed by the inguinal ligament. Base is above and apex. It is created by the meeting point of medial edge of adductor longus and sartorius. Okay. Lateral boundary by medial border of sartorius and medial boundary by the medial border of adductor longus. Medial border because adductor longus is included in the floor muscles, floor of the femoral triangle. So, floor it is a gutter shaped and muscular from lateral to medial. The floor of the triangle is formed by these muscles. From lateral to medial the muscles are iliacus, tendon of the psoas major, pectineus and adductor longus. Adductor longus is taking part in formation of the floor and also its medial border is forming the medial border boundary of the femoral triangle. Okay, that is important. Adductor longus. Now roof. Roof of the femoral triangle it is created by the fascia lata having the saphenous opening. Fascia lata is the deep fossa of the thigh. Deep fossa of the lower limb is known as the fascia lata. Okay. And here one opening is present that is known as saphenous opening through which the great saphenous vein is entering and draining into the femoral vein. Okay. Next, see here this region, this greenish area is the femoral triangle. Base is formed by inguinal ligament. These are the two boundaries. Lateral boundary is formed by medial border of the sartorius. Sartorius is going to be inserted into this tibia. Okay. And here is the adductor longus. Adductor longus is medial boundary of adductor longus is forming the medial border. Here are the neurovascular structures you can see entering into the femoral triangle beyond this inguinal ligament. Femoral artery, femoral vein and most laterally the nerve, femoral nerve. Okay. Next. So this is the boundary, the yellowish line is representing the boundary. Here is the sartorius, lateral boundary, adductor longus. See here this adductor longus is also forming the floor and also forming the medial border of the triangle. Here base is formed by the inguinal ligament. Here are the other muscles, iliacus, tendon of the psoas major, pectineus deep to these vessels, and here is the adductor longus. This muscle is also pectineus. Okay. So iliacus, tendon of, white colored ones, tendon of psoas major. Here is the pectineus, and this is adductor longus. These four muscles are forming the floor of the triangle from lateral to medial side. Okay, boundary is very important. Next. So borders, as this area is a triangle, it has three borders. Superior border, that is the base formed by the inguinal ligament, a ligament that runs from the anterior superior iliac spine to the pubic tubercle. And lateral border is formed by the medial border of the sartorius muscle. Medial border is formed by medial border of adductor longus. And the rest of this muscle forms part of the floor of the triangle. Okay. Next. Next, the superficial fascia. Overlying the roof, it includes these structures. These are important. Subcutaneous structures. Superficial branches of the femoral artery. There are three superficial branches of femoral artery. Okay. All and accompanying veins. All these are included. Upper part of the great saphenous vein, superficial inguinal lymph nodes, femoral branch of the genitofemoral nerve, and branches of ilioinguinal nerve. These are included within the superficial fascia over the roof of the femoral triangle. And the inguinal ligament, it acts like the flexor retinaculum of the hand. Okay, prevent bowstringing of these structures, supporting the content of the femoral triangle during flexion of the hip. Next. What are the contents? Contents are very important. Boundaries and contents of the femoral triangle is very important. Okay. So contents, the primary contents of the triangle are femoral artery and its branches, femoral vein and its tributaries, femoral nerve. All these structures can be given in your OSPI question. Okay. You have to identify the structure and related questions will be asked. Deep inguinal lymph nodes, 3 lymph nodes are present, and lateral cutaneous nerve of the thigh, which is direct branch from the lumbosacral plexus, not branch from this femoral nerve. In addition to the above structure, femoral triangle also includes the femoral branch of genitofemoral nerve and fibrofatty tissue. And these two structures, femoral artery, femoral vein, and another compartment is femoral canal. These three compartments forming the included within the femoral sheath, but nerve is not included within the femoral sheath. Okay. Next. So femoral triangle contains some of the major neurovascular structures of the lower limb. Contents are from lateral to medial. These positions are important. Lateral to medial. Most lateral is femoral nerve. It innervates the anterior compartment of the thigh and provides sensory branches for the leg and foot. And femoral artery is responsible for majority of the arterial supply to the lower limb. Femoral vein, great saphenous vein, drains into the femoral vein within the triangle. Another is femoral canal, a structure which contains the deep inguinal lymph nodes and some vessels. Okay. And the femoral artery, vein and femoral canal are contained within the fascial compartment known as the femoral sheath. Okay. Next. Next. Okay, femoral sheath, it is a femoral sheath comes as a long question. Okay, describe the femoral sheath, its contents, different compartments, all this. It is a funnel shaped fascial sheath enclosing the upper 3 to 4 cm of the femoral vessels. Femoral sheath is split into 3 compartments by 2 anteroposterior septa. What are these compartments? Lateral, intermediate and medial compartment. Its contents are important. Lateral compartment includes the femoral artery and the femoral branch of the genitofemoral nerve. Intermediate compartment includes femoral vein, and medial compartment, it is small and called the femoral canal. Okay. Next. See, these are the compartments. This is femoral sheath. This is from lateral to medial side. Lateral most is femoral nerve, which is not included within the femoral sheath. Here are the three compartments separated by this anteroposterior septa. Lateral, intermediate, medial. Lateral compartment contains the artery, intermediate contains the vein, and medial most is known as femoral canal. Okay, and these are the floor muscles you can see. Iliacus, psoas major, pectineus, and medial most will be the adductor longus. Okay, and this is inguinal ligament forming the base. Next. So now we will discuss the individual contents in details. Okay. So femoral artery and its branches. Femoral artery traverses the femoral triangle from the midpoint of its base to the apex of the triangle. An artery enters downward and medially. In the base of the triangle, it is located lateral to the femoral vein, but near the apex it is located anterior to the vein. One crossing is occurring in between these vessels and nerve. Okay. So the femoral artery has three superficial branches and two deep branches. Branches are very important, asked in your OSPI question. You have to identify the femoral artery, have to write down the branches. Okay, as a related questions, it can be asked. So superficial epigastric, superficial circumflex, superficial external pudendal. These are the three superficial branches, and two deep branches are present. Deep branches are profunda femoris artery and deep external pudendal. Profunda femoris is the largest branch of the femoral artery. Okay, all these are important for your MCQs also. Okay, next. Okay. See here the formation of the femoral sheath. Previous. Okay, so this is the femoral sheath, this greenish colored structure. So anterior layer of the femoral sheath, it is formed by the fascia iliaca. Fascia iliaca is the fascia covering the iliacus muscle, and posterior wall of the femoral sheath is formed by the fascia transversalis, okay, which is covering posterior aspect of the flat abdominal muscles. Flat muscles of abdomen from outside inward, it is the external oblique, internal oblique, and transversus abdominis. Deep to it lies this fascia transversalis. Okay, so these two layers are extending downward to cover the femoral vessels, forming the femoral sheath. Okay. See, this is the femoral sheath, 3 to 4 centimeter in length, and holding this proximal part of the femoral vessel and divided into three compartments. See, this is lateral most compartment containing the femoral artery and femoral branch of genitofemoral nerve. See here, and this nerve is lateral piercing the femoral sheath, and intermediate compartment contains the femoral vein. This is the vein, and medialmost compartment is known as the femoral canal, which is containing the deep inguinal lymph node. This lymph node is known as lymph node of Cloquet or Rosenmuller. Okay. Next, just see here different views. See, this is schematic diagram. You practice a schematic diagram like this, femoral sheath. Previous one and this one. See here, lateral compartment containing femoral artery and femoral branch of genitofemoral nerve. Silence everyone. So lateral compartment containing the femoral artery and femoral branch of genitofemoral nerve, intermediate compartment containing femoral vein, and medialmost is femoral canal containing lymph node of Cloquet. Okay, so these are the compartments. Here also you can see these three compartments: artery, vein, and femoral canal containing lymph node. Here also these floor muscles has been shown and three compartments. This is the femoral sheath. Artery with this nerve, femoral branch of genitofemoral nerve, here is the vein, and this is the lymph nodes. Lymph nodes are connected by the lymph vessels. Next, see, these are the content. There you can remember like a mnemonic, okay, navel from lateral to medial. Lateral most is the nerve which is not included within the femoral sheath. Then there is artery, then vein, then empty space is the femoral canal, okay, and then lymph canal. This is lymph canal, femoral canal. Next, and previous one. See, this is the great saphenous vein, superficial branch. The veins corresponding with the superficial branches of the femoral artery, they are draining into this great saphenous vein. And this great saphenous vein is ultimately drains into this femoral vein. Okay. Next. Next, we will discuss the femoral vein. Femoral vein accompanies the femoral artery, and vein is posterior to the femoral artery near the apex and medial to it at the base of the femoral triangle. And it gets the great saphenous vein and profunda femoris vein corresponding to the superficial branches of the femoral artery. Okay, all these veins are tributaries. Now we go to the femoral nerve. Femoral nerve is located lateral to the femoral artery outside the femoral sheath in the groove between the iliacus and psoas major, iliopsoas groove. Okay, this is important. Where it lies about 2.5 cm below the inguinal ligament, it divides into anterior and posterior divisions, which enclose the lateral circumflex femoral artery between them. That means lateral circumflex femoral artery, which is a branch from the profunda femoris, okay, that passes in between the anterior and posterior division of the femoral nerve. Now, what are the branches from this anterior and posterior division? Anterior division produces two cutaneous branches, intermediate and medial cutaneous nerve of the thigh. Medial cutaneous branch accompanies the lateral side of the artery, and at the apex of the triangle it crosses the front of the artery from lateral to medial. This point is important for your identification of this nerve, okay, this medial cutaneous nerve of the thigh. Okay. And this intermediate cutaneous nerve, it generally pierces the sartorius muscle, and another muscular branch is given from the anterior division. Muscular branch is supplying the sartorius muscle. Okay. So, two cutaneous branch, one muscular branch supplying the sartorius, and posterior division, it gives only one cutaneous branch and rest muscular branch. One cutaneous branch is known as the saphenous nerve. It goes downward along the lateral side of the artery, and muscular branches supplying the four muscles of the quadriceps femoris, okay, rectus femoris, and three vasti, vasti medialis, lateralis, and vastus intermedius. All these supplied by this posterior division of the femoral nerve. Okay. Next. Now, these are the clinical aspect of the femoral nerve. Femoral nerve injury, it may result due to wound in the groin, results in paralysis of the quadriceps femoris because posterior division was supplying, and sensory loss over the anterior and medial aspect of the thigh due to loss of medial and intermediate cutaneous nerve of the thigh and medial side of the leg. This is due to saphenous nerve. Okay. And what is femoral nerve block? Local anesthetic agent is injected around the femoral nerve to achieve the anesthetic agent that blocks the nerve condition by inactivation of sodium channels, and it is available as gels for local application or injection for nerve block. Nerve block is given during surgery of your lower limb. Okay, this is local block by injecting local anesthetic agent. Next is femoral canal. Femoral canal is the smallest anatomical compartment located in the most medial part of the femoral sheath, and it is approximately 1 to 1.3 centimeter in long, and the opening to the femoral canal is located at its superior border, and this opening at the superior border, it is known as femoral ring. This, all these terms are important: femoral ring, femoral septum, all this. Okay. Femoral ring is closed by a connective tissue layer that is known as femoral septum, and this septum is pierced by the lymphatic vessels exiting from the canal, and Cloquet's node is a lymph node situated within the femoral canal. This name is important, Cloquet's lymph node. This deep inguinal lymph node is known as Cloquet or Rosenmuller lymph node. Next, here is the femoral canal containing the lymph node. Okay. Next is lateral cutaneous nerve of the thigh. It appears underneath the lateral border of the psoas major muscle above the iliac crest, and it runs downward and laterally across the iliac fossa in front of the iliacus muscle under cover of the iliac fossa. It enters the thigh by passing below the lateral end of the inguinal ligament, and occasionally it goes through the inguinal ligament. It gives cutaneous innervation to the upper lateral aspect of the thigh. Okay, this is branch from lumbosacral plexus, not a branch from femoral nerve. You have to remember. Okay. Next, deep inguinal lymph nodes. Inguinal lymph nodes can come as a short node. So, okay, you have to write both superficial and deep inguinal lymph nodes. Here, this deep inguinal lymph node is related to this femoral sheath. That's why we are discussing this. So, the deep inguinal lymph nodes are generally 3 in number and located medial to the upper part of the femoral vein. The lowest one is located 3 in number. Okay, so lowest one is located below the junction of great saphenous vein and the middle one is within the femoral canal, that is gland of Cloquet or Rosenmuller, and the greatest one in the femoral ring, okay, at the upper margin within the femoral septum. Next, femoral pulse. Okay, when in some diseases, in severe dehydration or like this, when you cannot palpate the radial pulse is not palpable, then you can check femoral pulse. Okay, so femoral artery crosses exactly midway. The position is important. Femoral artery crosses exactly midway between the pubic symphysis and anterior superior iliac spine. Just inferior to where the femoral artery crosses the inguinal ligament, it can be palpated to measure the femoral pulse. And femoral artery crosses exactly midway between the pubic symphysis and anterior superior iliac spine, that is known as mid-inguinal point. Okay, position is mid-inguinal point. Now, access to the femoral artery, location of the artery is why it is measured, because it is easily accessible. Okay, an arterial tap. If you have to collect arterial blood, that can be collected from this femoral artery. Okay. Okay, so the location of femoral artery is easy to access because of its superficial location within the femoral triangle, making it suitable for a large range of clinical operations. One example is a procedure is known as coronary angiography. In this, the femoral artery is catheterized. These are important. Explain why question. Why cardiac catheterization is done through femoral artery? Okay, because it is superficial in location, easily accessible, and so the femoral artery is catheterized with a long thin tube, and this tube is navigated up to the external iliac artery, then common iliac artery, then aorta into the coronary vessels. And to view any wall thickening or blockages via X-ray, a radio opaque dye is injected into the coronary vessels. That is how coronary angiography is done. Next is femoral hernia. What is hernia? Hernia is defined as a condition in which a part of an organ is displaced or protrudes through the wall of the cavity containing it. In the case of femoral hernia, part of the bowel pushes into the femoral canal and underneath the inguinal ligament, and this creates a lump or bulge in the area of the femoral triangle and it requires surgical intervention to treat. Next, see, this is the herniation is occurring. This bowel content intestine is herniating through the femoral canal, okay, and also it is coming out through this saphenous opening. Here is the saphenous opening. See, the great saphenous vein was draining into femoral vein through this opening. So this intestine is passing through the femoral ring, then into the femoral canal, then it is coming out through the saphenous opening and forming a bulge over the femoral triangle. Next, so femoral hernia is herniation of the content of the abdomen through the femoral canal. Femoral canal is the medial compartment of femoral sheath. Femoral hernia is more common in females. There is a very important explain why question. Why femoral hernia is more common in females? Okay, femoral hernia is more common in females due to females have wider femoral canal and smaller femoral vessels. Okay, so it will get more space for herniation. So femoral hernia is common in adults than children and is never congenital. Congenital hernia does not occur. For inguinal hernia there may be congenital hernia. Okay, for femoral there never congenital hernia occurs. So what are the composition? What structures can come as a hernial content? Hernia consists of coverings and loops of intestine, peritoneum and blood vessels. Hernia has a neck and a sac. Neck is the narrow part and sac is the bulging part. Okay. What is the course of the hernia? How it comes out? First, the hernia passes downward through the femoral canal, then forward through the saphenous opening, then pushes upward along the superficial epigastric vessels. So you have to reduce the hernia. How will you reduce? Opposite to this direction. First you have to push it downward, then forward, then upward. Okay. So this is the duration of push during reduction of the hernia. That is important. Astenoviva. Hence, for reduction of femoral hernia, reverse course should be followed. Next. So here, these are the classification of femoral hernia. Reducible femoral hernia, when the contents of hernia can be pushed back into the abdominal cavity. Irreducible, that means when a hernia cannot be pushed back due to adhesion between the wall of hernial sac and its content. Obstructed femoral hernia, when a part of intestine in the hernial sac gets obstructed due to twisting or constriction. And strangulated femoral hernia, when there is a loss of blood supply to the herniated intestinal part and it requires surgical correction to widen the femoral ring and reduce the hernia. Okay, so these are the 4 types of femoral hernia. And reduction of the hernia in their normal anatomical position is important and it can be done manually or surgically based on the type of hernia. Generally, this obstructed and strangulated, these are severe cases and these are corrected by surgically, and this reducible, irreducible, it can be reduced manually. Okay. So these are the, see here the herniation, okay, through the femoral canal. These are the outer covering. Outermost will be the skin, then the here is the cribriform fossa of the femoral ring. Then here is the femoral sheath, okay, and this is the peritoneum. The blue one is the peritoneum covering the, and this is the gut loop, okay, intestine. So these are the covering and content of the femoral hernia. Next, so these are the 4 floor muscles you can see. See, this is base formed by inguinal ligament, lateral boundary formed by the medial border of sartorius, medial boundary is formed by medial border of adductor longus. So floor muscles from lateral to medial, iliacus, tendon of psoas major, pectineus and adductor longus. Okay. Next, see here, this is profunda femoris artery, largest branch from the femoral artery, okay, profunda femoris, which is giving lateral circumflex femoral artery, which is passing in between anterior and posterior division of the femoral nerve. See here the branches of anterior posterior. From the anterior division, see, this is the medial femoral cutaneous nerve crossing near the apex From lateral to medial, the femoral vessels, okay, and this is intermediate femoral cutaneous nerve piercing the sartorius muscle, okay, and also the muscular branch is supplying the sartorius muscle. From the posterior division going along the artery, this nerve is the saphenous nerve, which is the cutaneous nerve, and muscular branches will supply the quadriceps femoris. Next, different branches of the femoral artery has been shown. See, these are the three superficial branches: superficial epigastric, superficial external pudendal, superficial circumflexilia. And this is deep branch, deep external pudendal. Here is the profunda femoris. Profunda femoris again giving branches, perforating branches, and lateral and medial femoral, medial circumflex femoral artery. Okay. Next, see, lateral and profunda femoris giving the lateral and medial circumflex femoral. Lateral circumflex again dividing into ascending, transverse and descending, and medial is also dividing into ascending and transverse and taking part in formation of the different anastomosis, okay, trochanteric, cruciate anastomosis, and these are the perforating branches, terminal branches from this profunda femoris artery. Next, see, and these perforating branches are forming an anastomotic chain on the posterior aspect of this adductor magnus. Okay, here is the cruciate anastomosis, here is the trochanteric anastomosis, formed by branches from medial and lateral circumflex femoral arteries. Next, this is the femoral sheath. You can see the pink one, compartment, lateral most containing the artery and femoral branch of genitofemoral nerve, intermediate containing vein, femoral canal, and upper end of the canal is femoral ring covered by the cribriform fossa, okay, femoral septum, and this is the reflection of deep fossa forming the saphenous opening, okay, through which the great saphenous vein is going to drain into the femoral vein, and the superficial branches of the arteries coming out, superficial epigastric and superficial external pudendal. Next, this is formation of the femoral sheath, okay, by extension of fossa iliaca and fossa transversalis. These are pulled downward along this artery and vein and forming the femoral sheath, okay. Next, this is the formation of the femoral sheath. Here is the cribriform fossa. Next, different nerves and its different branches, okay. Branch to vasta, different vasti from the posterior division. Next, okay, that's all.
Water soluble vitamins, correct? In the first class, Dr. Pal, I think, have taken B1 and B2, right? So today we will see the other small topics. These are very small topics. Mostly they are not so important for long questions. So we will quickly go through. Biotin, also known as vitamin B7. So its structure consists of two rings, a fused structure of imidazole ring and one thiophene ring, plus one valeric acid. Valeric acid means how many carbon? Very easy to remember. See, this is what? What does it look like? Roman 5. So V for 5 carbon compound, right? So 5 carbon organic acid. Fine. Now tell me, what is this ring? This is the whole structure of biotin. What is this ring? Imidazole. And what is this ring? Thiophene. See, thiophene, imidazole. And this is valeric acid. See, 4 plus 1, 5 carbon compound. Right? So this is the structure of biotin. Where do you find biotin? In egg white. It is also called vitamin H, and it is called as anti-egg white injury factor. Anti-egg white injury factor. Sources: egg yolk, cereals, legumes and nuts. Now, when you mix the yolk with the egg white, the function or biological function of this particular vitamin is lost. When you make an omelette, the biological function of this particular vitamin is lost. Why? Because it mixes with avidin, the biological counterpart of biotin, which is found in egg white, and this is found in egg yolk. So when you make it omelette, these two, they cling to each other and its biological function is lost. So in order to get biotin, what you should take? Raw egg yolk. When you say egg yolk, that doesn't mean omelette. You separate the egg yolk and eat it as such. That's all. You will get more vitamin H than any pills. Okay. Quickly go through. Being water soluble, it does not require bile salts for its digestion, unlike its counterpart in the fat soluble vitamins, for whom bile salt is must. But for these, bile salts are not required. So absorption can take place easily and freely without any influence of bile salts. Now, what are these biotinidase? This deficiency due to inborn error has been documented in infants and children with clinical features. Suppose this biotin is deficient, or any food particle which contains this particular enzyme will destroy the biotin present in the diet. So even if you take good amount of vitamin, it will not be found in absorbable condition. So you will have biotin deficiency, or vitamin H deficiency. Transport, storage, function. Let us concentrate on function. Biotin is mostly found in association with carboxylation reactions. Can you name any carboxylation reaction? Anyone? So far you have studied any carboxylation reaction? Anyone? Any carboxylation? Many are written here. Which one you have studied so far? Pyruvate carboxylase. Correct? So can you recall what was the reaction? The reaction involves ATP. Reaction involves ATP. In order to attach one carboxyl group, CO2 group, we need to break one molecule of ATP. And this particular ATP should be broken in very close vicinity to the reaction process. For that, it should be bound with biotin. So biotin holds the carboxylic group and it assists in hydrolysis of ATP, and that energy is transmitted through biotin for addition of this carboxylic group to the given compound. So wherever there is carboxylation reaction, make sure you write ATP and biotin. ATP is converted to ADP, phosphate is given, phosphate is broken down to ADP plus PI, and the biotin will add the carboxylic group to the given compound. Okay. So here few examples have been given. So this one you know, pyruvate carboxylase. Can you recall the reaction? Can you write the reaction? Pyruvate to oxaloacetic acid. Pyruvate to oxaloacetic acid. Can you tell me this one? Most probably not. This is acetyl-CoA carboxylase. Write down the reaction. Acetyl-CoA carboxylase. Acetyl-CoA gets converted to malonyl-CoA. Let me write at least one reaction which I have studied before today's class. At least one reaction I should write. Okay, so acetyl-CoA carboxylase, this type of reaction, CO2 plus ATP, ADP plus PI, CO2 is added to here. So 2 carbon compound acetyl coenzyme A becomes now 3 carbon compound malonyl coenzyme A. Where do you find this reaction? Anyone? Fatty acid biosynthesis, de novo synthesis of fatty acid. In the pathway of de novo synthesis of fatty acid, we find this reaction. Propionyl CoA carboxylase. Anyone? Yes? কি বলো? হ্যাঁ? দাঁড়িয়ে বল। Gluconeogenesis, very good, very good. What is the product? Substrate and product? Dimethyl malonyl CoA, propionyl CoA carboxylase. Correct? Good. So this is a reaction where through which propionyl CoA enters into TCA cycle, through succinyl coenzyme A. So this is a type of anaphylactic reaction, or catabolic pathway. Next, beta methyl protonyl CoA carboxylase. This is very difficult, you never heard of it. This is an enzyme in branch chain amino acid catabolic pathway. Branch chain amino acid catabolic pathway. Okay. All those reactions have been shown in this single pathway, single slide. Beta methyl protonyl CoA carboxylase, BMCC. 3-methyl protonyl CoA to 3-methyl gluconyl CoA. From there, it forms acetyl coenzyme A to malonyl coenzyme A, then fatty acid, or it goes to TC cycle via citrate formation. Okay. Just go through it slowly, starting from any one end, either this end or that end. All the water soluble vitamins are important for as cofactors or coenzymes. So you need to remember as many as possible reactions. If you remember reactions, you remember the coenzymes. If you remember coenzymes, you have to remember reactions. Fine? Any question? 4 enzymes have been shown, see, by a 4 black box. Correct? Any question? Should not be. Toxicity, remember, no water soluble vitamin shows toxicity. If you eat more, no problem, nothing will happen, nothing will go wrong, except one, that is vitamin C. In some papers or some researchers say too much of vitamin C might be harmful, but still there is a question mark. Now here, biotin deficiency, what are the symptoms of biotin deficiency? Now remember, alone biotin deficiency patient will not come to you. They will come with multiple vitamin deficiency manifestation. Okay? So these were produced experimentally on animals or human beings, mostly during Second World War on the prisoner of wars, for whom they need not to give any clarification to anybody before pursuing any experiment on the human being. Okay? So this is a dark truth of the discovery of this deficiency manifestation of these particular vitamins, that it was done on human being, mostly on the POWs during Second World War. Now, it was found that deficiency of particular these component of diet shows dermatitis and hair fall, alopecia, neurological disorders, lethargy, low blood sugar, high blood ammonia, acidosis, hallucination. Obviously, if a particular substance is missing, which is so pertinent for normal metabolism, the normal health and physiology will be down, and person will show severe malnutrition symptoms. Correct? What is avidin? Avidin is a glycoprotein found in egg white. What is its use? It is the most widely used substance in biological field. Can you remember there is a technique called affinity chromatography? Do you know something about ELISA? The ELISA, when we want to identify certain particular antibody and identify that antibody by a particular substance, we usually add one biotin to that particular antibody, and another substrate we add with avidin. So wherever that antibody will be present, it will hold the biotin in the solution, and this substrate along with avidin will come and attach to biotin avidin affinity. So it will identify the presence of the previous antibody, and the substrate will show color reactions to identify the presence of particular antibody. This is how we make the color reaction happen during enzyme linked immunosorbent assay, or more popularly known as ELISA. Clear? So biotin and avidin is used for these. It is also used for affinity chromatography. Certain substances might be attached with avidin, can be separated using biotin in the column. Correct? Very highly, they have very high affinity towards each other. But avidin is denatured upon cooking eggs and does not have an effect on biotin absorption. So that means if we boil the egg, we can destroy avidin, and boiled egg yolk will contain biotin. Yes, it will be destroyed to some extent, but not whole. That's why half-boiled egg, eating half-boiled egg has come to a practice, because that mostly 90% denatures the avidin, but biotin remains unharmed. Next, pantothenic acid, B5. Pantothenic acid is found as a part of one coenzyme called coenzyme A. See, it has got two parts. One is pantoic acid, this one, another this is beta-alanine. Now alanine means alpha-alanine, beta-alanine means still it's an amino acid, but beta amino acid. So beta-alanine is a non-standard amino acid. It is not found in any naturally occurring protein. It is found in association with some other compounds, like here, pantothenic acid. So it is a part of coenzyme A. Coenzyme A, that's acetyl coenzyme A, propionyl coenzyme A. All these things we have heard of, succinyl coenzyme A, alpha-ketoglutarate coenzyme A. What is the function of this coenzyme A? Can anyone tell me? If I ask you, what is the function of coenzyme A? Anyone? Prival? চেষ্টা কর। আমি কি বললাম, কতগুলো কম্পাউন্ডের নাম নিলাম, এই সবকটা কম্পাউন্ডের মধ্যে কি কমন? সাকসিনাইল কোয়ে, মেলোনাইল কোয়ে, প্রোপিনাইল কোয়ে, অ্যাসিটাইল কোয়ে, কি কমন? চিন্তা কর। হ্যাঁ, আরে কোয়েঞ্জাইম তো কমন বটেই, তাহলে আর বাকি বাকি এই চারটে কম্পাউন্ডের মধ্যে কি কমন আছে? মানে কেন, হোয়াট ইজ দ্য ফাংশন ইফ আই আস্ক ইউ? সো হোয়াট ডু দে ডু? Why they are attached to here? Acyl CoA, propionyl CoA, acetyl CoA, succinyl CoA, है ना? हाँ? Carboxyl group R2. अच्छा, अच्छा, what is the function of glucuronic acid? What is the function of glucuronic acid? It helps in the transport of bilirubin. What is the function of coenzyme A? Can you now relate? Transporter of acyl group. Acyl group. Acetyl, propionyl, butyryl, glutaconyl. What are these? These are acyl group, aliphatic chain acid. So these acyl group are transported via coenzyme A. Clear? So that is why they are required for formation of fatty acid, formation of cholesterol, formation of keto acids, means ketone body, है ना? Acetyl CoA, acetyl CoA, where they are used? For formation of these compounds, free fatty acid, cholesterol and ketone bodies. Clear? Now this is the structure of coenzyme A. This SH is very, very important. Now fine, we come to this part, pantothenic acid in the middle, in the right side, this is adenosine. They are called coenzyme A. This is a part of nucleotide. See, this is a nucleotide, then one pantothenic acid, organic acid, and then one amino acid, cysteine, SH. Three parts, adenosine, pantothenate, cysteine. Adenosine plus pantothenate plus cysteine. Okay, तीनटे part. Next, niacin. Niacin, it is colorless and it is water soluble and derivative of pyridine or pyridine. Now what is pyridine? Let us see the chemistry. It is found in two forms. Nicotinic acid, which is called niacin. Know the names, that's all. Know the names. Hey, মুখে ধুইয়া মশা, মুখ বন্ধ কর, জল খা, drink water and wake up. Nicotinamide or niacinamide. Know the names first. Their forms, very easy to remember the structure, very easy. See, this is pyridine, to which one carboxyl group is added, so it becomes nicotinic acid. When this group is added with an amino group, NH2, it becomes amide, so it becomes nicotinamide. Now this has nothing to do with what we inhale through smokes. There is no pathway of formation of niacin or nicotinic acid from nicotine. Nicotine is completely different compound. This has nothing to do with nicotine. Although names are very close, but nicotine is completely different compound. There is no biological pathway which can produce niacin from nicotine. If you can make it a Nobel Prize for you, because then all doctors will prescribe correct? All doctors will prescribe, which is now written injurious for health, then it will be written beneficial for health. Okay? Now fine. Now the problem is nicotine is no harm for us, not harmful. Problem is the way we take the nicotine. If we take nicotine through patches, through tablet, nothing will be harmed. But problem is the way we take. The mode of inhaling is not good. Fine. Anyway, so you are just a step away from Nobel Prize. What are the coenzyme forms of niacin? Two forms, NAD and NADP. Read the names, what you might have read in class 10, just refresh your memory. Nicotinamide adenine dinucleotide. Nicotinamide adenine dinucleotide phosphate. Can you tell me in which reaction NAD will be used and in what type of reaction NADP will be used? Bolo? The reaction which will take place in cytosol will contain NADP. The reactions which will take place inside any subcellular organelle will require NAD. Say reactions within mitochondria will require NAD plus. Reactions in cytosol will require NADP. Then kindly tell me where this reaction takes place. Glyceraldehyde 3-phosphate dehydrogenase. It is a part of glycolysis. Glycolysis takes place in cytosol. So what I told is incorrect. Justify. Justify this when I say the reactions occurring in cytosol requires NADP and reactions occurring in membrane-bound subcellular organelles require NAD. Now, glyceraldehyde 3-phosphate dehydrogenase is an enzyme of glycolysis which takes place in cytosol. Justify that it is not overruling the previous rule. These reactions which require NAD plus occurring in cytosol, they are actually located as membrane bound. NAD plus cannot travel a distance, a considerable distance during reaction in aqueous medium. Remember, NAD plus cannot travel long distance in aqueous medium. It gets discharged. Clear? So it cannot carry electron in aqueous medium. It must be water-free atmosphere, and that is possible in only where there is lipid. Where do you find lipid? In plasma membrane, cell membrane, mitochondrial membrane. So these enzymes, which is part of glycolysis, are actually membrane bound. NADP, whereas on the other hand, can be found in cytosol because it is already added with phosphate. Already added with phosphate. So NADP is much more stable than NAD plus. Now the structure of NAD and NADP. Right? Why do you call it dinucleotide? These are small viva questions. I tell you. Why do you call dinucleotide? What are those nucleotides? What are those two nucleotides in the structure? What is this? Nicotinamide. To these attached this ribose, phosphate. And what is this? Actually, it looks like what? It looks like nitrogen base. So if you half the molecule from here, then this part is look like a nucleotide, nitrogen base, ribose sugar and phosphate, and this side nitrogen base, ribose sugar, phosphate. So nicotinamide, adenine, dinucleotide. So one is nicotinamide is one nitrogen base, adenine is another nitrogen base, two ribose and two phosphate groups. Clear? That's why it is called dinucleotide. That's why it is called dinucleotide. Clear? If it is in a DP, then phosphate is attached here. 2' away, 2' hydroxyl group. Absorption is same. RDA in milligrams. Write anything in milligrams, 10 to 20. Okay? Biosynthesis only by bacteria we cannot synthesize. We synthesize this part. See, 60 milligrams of tryptophan. This is sometimes they ask. 60 milligram of tryptophan give rise to 1 milligram of niacin. Means from 60 milligram of tryptophan if we consume, we can metabolize and produce 1 milligram of niacin. It's very less. That's why we need to replenish niacin through other dietary components. Okay, and this particular pathway requires these two other vitamins, means B2 and B6. That is why I say when there is one deficiency of one of these water soluble vitamin takes place, the patient actually manifests with deficiency of multiple vitamins. So we prescribe not a single vitamin, we prescribe the whole vitamin group, Bicosol capsules, so that all vitamins are supplied. Clear? Sources, write anything and everything you eat, just write those. Burger, don't write like this, biryani, burger, pizza, tandoori chicken. Please write the name of the food, not the name of the recipe. Okay? Do not write like this, biryani, tandoori chicken, kebab. No. Please write the name of the food, not the name of the item. Biochemical function, two functions. One is coenzyme function, another is they prevent pellagra type of disease. A disease called pellagra. So they are called also pellagra preventive factor, PPF. Pellagra preventive factor, PPF. These are the names, list of names of few enzymes which require NAD for their function. Few enzymes you can also name by this time. Glycerol 3-phosphate dehydrogenase, pyruvate dehydrogenase, lactate dehydrogenase, these three you can name. Correct? Anything else? In TC cycle, IDH, isosociated dehydrogenase, alpha reticular dehydrogenase, malate dehydrogenase. তাহলে পাঁচটা আমি বলে দিলাম দেখো না so remember the names which require NAD. NADP, mostly NADP is required in reactions which are part of biosynthetic pathways. NADPs are required in biosynthetic pathways. Say for example, biosynthesis of cholesterol, biosynthesis of fatty acid. So these pathways are called reductive biosynthetic pathway. They require reduction in biosynthetic pathways. There we require NADPH, NADP, etc. Okay. Cholesterol biosynthesis, fatty acid biosynthesis, purine biosynthesis, non-essential amino acid biosynthesis. And these two reactions, you remember? Last two reaction? Part of which pathway? Which pathway? Pentose phosphate pathway. And this is, where did you find this reaction, this enzyme? Glutathione S reductase, where do you find this reaction? What is the function of this enzyme? To maintain RBC membrane. RBC membrane integrity. Good. Enzymes which can utilize both means not together, either of these they can use. They can use NAD, they can also use NADP, only one. There is only one enzyme in our system which can utilize any one of these, NAD or NADP, that is glutamate dehydrogenase. Now can you tell me which type of reaction it actually catalyzes? Glutamate dehydrogenase, oxidative deamination, glutamate dehydrogenase, oxidative deamination reaction, glutamate dehydrogenase, glutamate to alpha ketoglutarate. It forms glutamate to alpha ketoglutarate. It is one of the reaction which may replenish one of the intermediates of T-cell cycle. It is found in mitochondria of hepatocytes. It is very, very important for production of ammonia in liver, where this ammonia is channeled into urea cycle. Without this reaction, our liver cannot metabolize ammonia. This enzyme is so important. Correct? So this is important for production of ammonia in the liver. It is not found in anywhere else. It is found in mitochondria of hepatocytes. Clear? You can utilize either of these, NAD or NADP. GDH, glutamate dehydrogenase. Now, deficiency manifestation of niacin. It leads to a disease called pellagra. Pellagra is a disease of 3 Ds. Diarrhea, dementia, dermatitis. Diarrhea, dementia and dermatitis, 3 Ds. If untreated, the 4th D come into action. That is a fixation of meeting with the Almighty. Appointment with Almighty. So when you don't treat it in time, you find the 4th D, that is death. Dermatitis, diarrhea and dementia. Okay? এই দিন বলতে হবে, আর কিচ্ছু না, nothing else. It is found in 3 different forms. Pyridoxine is found in 3 different forms. Pyridoxine, pyridoxal, pyridoxamine. One is alcohol, aldehyde, amine. Pyridoxine, alcohol, pyridoxal, aldehyde, and now this particular vitamin is somehow linked with Calcutta. Many work regarding this vitamin have been done from Calcutta University. Okay, that's why the scientists of this part of India, they coined a separate name for this pyridoxal phosphate as PALPO, P-A-L-P-O, which is a name which is used only by Indian scientists and the subcontinent scientists didn't. Nowadays, it has been replaced by PLP as in the other part of the world. Okay. Where do you find? It is mostly synthesized in our body by intestinal flora, and rest of it we will find from any type of fruit, vegetables, meat or dietary component. Clear? RDA, right? Milligram. What is the difference between RDA of fat soluble vitamin and water soluble vitamin? Fat soluble vitamins RDA are in microgram, and they are in milligram. So which one is higher? Milligram. We need more because we lose more. Now the reactions which they participate in, like biotin is required in carboxylation, pyridoxal phosphate is required in opposite, decarboxylation. Pyridoxal phosphate is required in transamination. There are two reactions which cannot happen without pyridoxal phosphate. One is decarboxylation, another is transamination. Are there any exception? Yes, there is an exception. আমার জানাতে না মানে তোমার লিখতে বলছি. Write down the exceptions. Okay, so they participate in two types of reaction. One is decarboxylation, another is transamination. All transamination reaction must require PLP. Without PLP, no transamination can take place. But there are few decarboxylation which does not require PLP. Write down. Ornithine decarboxylase. Ornithine decarboxylase, one of the enzyme of polyamine biosynthetic pathway. One of the enzyme of polyamine biosynthetic pathway. Clear? Does not require PLP. Does not require PLP because it has inbuilt pyruvate molecule. Because it has inbuilt pyruvate molecule. Fine. Now let us come to the third reaction, allosynthetase. Where did you find this allosynthetase? The heme biosynthetic pathway. Heme biosynthetic pathway. Heme biosynthetic pathway starts with allosynthetase. So in PLP deficiency or vitamin B6 deficiency, heme synthesis will be affected. And why we will have PLP deficiency? Because of the effect of certain drugs. There are certain drugs which require vitamin B6 or PLP for their detoxification. If you consume certain drugs, they require B6 for their detoxification, which takes place in mostly liver. And it depletes, the process depletes the B6 store in the body. So we need to take more B6 through diet. And if we fail to do so, then B6 deficiency takes place. Correct? So that is allosynthetase. We'll come to that. Causes of B6 deficiency. See, this is very, very important. Let's go through it. Individuals with poor quality of diet, poor person cannot eat. Malnutrition, one of the cause. Inadequate B6 intake. Second is chronic alcoholics. Chronic alcoholics will show B6 deficiency. Chronic alcoholics. So find out the history of the patient. Do you consume alcohol? in what frequency, find out whether it is chronic alcoholic or not, whether he is taking diet regularly or not, then that might be a cause of B6 deficiency. Chronic alcoholic also promotes the destruction of loss of B6 from the body. Older people, they cannot absorb. The power of absorption is fairly reduced in old age people. They cannot absorb from the diet. So they should be given higher dose of vitamins for absorption. Then patients who are taking anti-asthmatic drugs like theophylline, children mostly, small children, they suffer from asthma, the doctor has prescribed theophylline, so they taking theophylline, they might show B6 deficiency. So find out history from the patient for any of these. Okay, try to remember these points. Sometimes this will be asked as a clinical question. So you must remember these lines. I tell you, in the clinical question, you all mostly fail to identify the disease. The clinical question is so difficult because if you do not identify the disease, you lose the whole marks. There is no partial marking. And if you just identify the name, you will get more than 50% marks. Even though you cannot explain the mechanism, you should just identify, you will get marks. Okay, so just always remember these lines. Always remember these lines. Find out why that is happening. You must remember these lines. If the cause is not here, you cannot see on the patient. You must remember the causes. What are the other manifestations? Sideroblastic anemia and convulsions among the infants. What are the drugs? What are the drugs that interfere with B6 metabolism? Means over-utilizes B6. So patients, the story will come like this: a patient undergoing such and such therapy. You must remember that if the patient is undergoing such and such therapy, he should be having that type of drug. Is that drug present in the list? If yes, that means the consumption of this type of drug may be a cause for B6 deficiency. So they will give you only the type of therapy. They may not give you the name of the drug also. So you must remember where we use these drugs. Chloramphenicol, what is this? Chloramphenicol, antitubercular drug. Antibiotic. Oral contraceptive pills, OCPs. Okay, so a patient undergoing taking OCP might show B6 deficiency. So this is not possible for any male patient. Not possible for male patient. So keep this in mind. This may be possible for anyone. Cycloserine. Again, this is a bactericidal substance. It is normally it comes as a poisoning. If found in an ointment, small children, they might swallow it accidentally. Isoniazid, this is what you call anti-tuberculosis drug or anti-tubercular drug. Isoniazid, INH. L-dopa, mood building substance. Psychiatric people, they are given L-dopa. Psychiatric patient, some psychiatric patient, to improve the mood, dopamine metabolism. Correct? So they utilize B6 from the body. So remember these drugs. And girls. 2 minutes. Whatever I taught today, what are the important things from this particular topic? Number one, Remember pellagra? Pellagra. Next, coenzyme forms of these vitamins. Name of the coenzyme forms of these vitamins. Okay. Different form of niacin. Different form of niacin. Next, 1 milligram of niacin is produced from 60 milligram of tryptophan. This line is important. 1 milligram of niacin is synthesized from 60 milligram of tryptophan. This line is important. Write it separately. Next, coenzyme A, its composition. Coenzyme A composition. Biotin requiring enzymes. 4 reaction আছে, 4 reactions. এনজাইমের নামগুলো মনে রাখতে হবে। You have to remember the names of the enzymes. Next, name the enzyme which can use both NAD and NADP. Both NAD and NADP. Clear? Name of the drugs which interfere with metabolism of B6. Last slide ta. Hello? আর কি বললাম? বায়োটিন। ও ফলিক অ্যাসিড আছে তো। এই খোল 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 পরেরটা খোল। পরেরটা খোল পরেরটা খোল পরেরটা খোল। হ্যাঁ ফলিক অ্যাসিড বাদ চলে গেছে। এটা বড় কোশ্চেন আছে। এদের সবারই RDA হচ্ছে 1.5 থেকে 2, 1.5 to 2 মিলিগ্রাম পার ডে। কমন RDA 1.5 to 2 milligram per day. Bas. Okay, that's all.
So we'll be quickly going to analyze this particular microanatomy of the organs, which is relatively easy and one of the high yield areas of identifying the microanatomy, which is the pancreas tissue. So you have learned this particular different sort of tissues. This kind of organ which you are seeing, a new kind of organ which is kind of unique in a sense that this particular organ is a gland which is present in our GI system, and this particular gland is responsible for the digestions of the food particles, predominantly fat particles, predominantly protein particles. So it has a capacity of secreting some enzymes, we call them as pancreatic juice or pancreatic enzymes, which is coming over here. So that makes this particular gland as an exocrine gland. As we have seen this particular thing which is coming through the duct system, we call them as exocrine gland. There is liberated from the gland, channeled through the ducts and liberated in some parts of the GI tract, and then it gets the food particle which needs to be digested or needs to be broken down into smaller pieces, and then this absorptions of these particular smaller particles of these protein, fats, etc. will be taken up. Now, besides this particular exocrine functions, this particular pancreas has other functions which is also known as endocrine functions. So, this particular organ has a dual entities or two kind of like jobs that it has to do. Exocrine functions for the digestions of the food particles, which is a majority of this particular organ is dedicated to, and very small and precise region of this pancreas is dedicated to have another functional area. We call them as the endocrine functions. So, that particular endocrine functions is that it has some areas which is cells which is producing some kind of like chemical substance which is protein in nature. They are not related to this duct system, they are liberated in the blood system itself, and in the blood they are absorbed and they runs through the blood system and controls different parts of the organ, body, functional, etc. So, that part we call them as the endocrine functions. So, it has two functions to perform here physiologically, endocrine functions and exocrine functions. So, whenever you are seeing this particular anatomically, we will see that this particular organ have got different shapes and different morphologies. We call them as this particular organ has a head, then we have a narrow part, we call them as neck, then we have the middle part which is known as body, and then has a fagging part, we call them as tail. So, if you see this particular organ which is looking like a comma shaped organ, just like the English letter comma, which is made this particular comma horizontal, it has a carved C-shaped area, neck, body and tail. That is how it looks like. And through this particular entire gland system, it is pierced by a channel system, which is the collecting duct system. That means it has a duct which is carrying through is the pancreatic juice or pancreatic fluids. Now, it has two kinds of duct system which is present in here, which is the major pipe there, we call them as main pancreatic duct, which is thicker one. Along with that, we have some sections of this pancreatic duct has another channel system, we call them as minor duct system, we call them as accessory pancreatic duct. There are two kinds of duct system which pierces and collects all these particular exocrine hormones, exocrine enzymes through it. We call them as pancreatic duct of Wirsung and accessory pancreatic duct of Santorini. So, these are the things which is carrying this particular exocrine juices which is coming from this particular pancreas. Now, as we have seen these particular organs which is producing some kind of enzymes, just like the parotid gland, we have seen the parotid gland which is capable of producing secretions which is known as the saliva secretion. Now, basically we have identified this particular morphology of the cells which is present in the salivary gland based on this particular nature of this particular fluid. How this particular fluid is coming, is it a watery in nature or it is a sticky or mucoid in nature. Based on that, we call them as this particular pancreatic tissues as it could be like the acinar, which is made of like the fluid which is called like this like fluid acini or mucinous acini based on this particular nature of the fluid which is present. Now, this particular pancreas, the fluid which is coming from the pancreatic juice is predominantly liquid or watery in nature. So, this particular mucoid variety which you have seen that snowflake appearance of this particular cells which is not present. So, this particular pancreas, as you see that we are going to break down the microanatomy, we are going to see these two entities. One is the secretory functions which is coming from the exocrine and as well as endocrine functions are there. The endocrine functions is not entirely present in this particular gland. There are some regions of this particular pancreas which is predominantly seen to have the endocrine functions, predominantly saying the body which is related to the tail and the tail of the pancreas. These are the areas where we see the predominant areas of these endocrine functions. That means the endocrine cells are located predominantly in the tail region of the pancreas and the body of the pancreas. These are the regions. Now, if you see this particular picture of this particular pancreas, you see that this particular region we call them as head of the pancreas, which is pushing towards this particular duodenum. This is the second, third and fourth part of the duodenum into which this particular pancreatic head is incorporated, just like fisting hand which is putting inside to this particular circular seal loop of the duodenum. So, this is the head end. We do not see this particular endocrine functions or endocrine cells in this particular head region or neck regions. As we move from this particular neck region to the body and body to the tail which is towards the spleen side, we see more and more predominant cells which is isolatedly present, and we call this particular isolated cells which is floating into this pancreatic tail and pancreatic body which is related to the splenic region. We call them as islets of Langerhans. That means they are floating on the sea as islets, right. So, that is why we call this particular area of the endocrine regions in the pancreas as islets of Langerhans, which are dedicated cells for the endocrine functions. So, these are the two basic elements of this particular pancreas. Now, this particular pancreas has a covering capsule just like any particular organ we have, and this particular capsule splits down to this particular parenchyma of the pancreas and splitting into the small lobes and lobules, etc., etc. So, this is how it is going, but this particular capsule is very thin walled, not that particular thick capsules which we already have seen in case of this pancreas, spleen, lymph nodes, etc., etc. So, very thin capsule is there, but this particular capsule is not restricted to the outer covering, rather it penetrates deep to this particular pancreatic tissues and splits this into small lobes into this particular pancreas. And as we have mentioned, this particular pancreas has exocrine and endocrine functions. We are going to see this particular exocrine component of the pancreas which is predominantly seen, and some of the areas of endocrine areas we call them as islets of Langerhans. These are the two entities we are going to address in this particular session or in this particular class. Now let's deal with this particular exocrine functions. Now we mentioned this particular fluid which is coming from this particular pancreatic juice is coming, and for the digestive material it is coming. They are not mucus rich. That means they are rich in proteins. This particular protein rich fluid which is coming here, we call them as serous kind of glands. Now if you see this particular secretory unit of anything, we call them as acini, right? We mentioned this particular thing, the word beforehand as well. So acini, which is a secretory functional unit of any kind of gland. Now this particular acini consists of two elements. One is the cell which is producing the secretion. Second thing, this particular cells is supported by some kind of cells which is capable of contracting it. That means extract this particular juices out of this, and once this particular juices is out of this, coming out of this particular element is thrown into the pathways which is taking this particular juice out of this tract, which is collecting system. That means we are going to see some duct system as well. So these are the three functional element of this particular pancreatic exocrine element we are going to see whenever we are going to address it. So we make this particular thing simple as secretory part. We call this as acini, which has get particular cells which is producing this particular secretions. Once these secretions are there, they needs to be pumped out by some kind of cells. We call them as centriacinous cells, which are kind of contractile cells. They are capable of contracting and producing this particular secretion dumped into these channels. These particular channels we call them as ducts. Now depending on ducts, how these particular ducts are there deep into the pancreas, we call them as intercalated ducts, interlobar ducts, interlobular ducts, main duct, accessory duct, etc., etc. So that's how we narrate this and classify this particular entire element. So this is a secretory unit. We call them as acini. These cells we call them as acinar cells. Now how do the cell look like? Triangular, oval kind of things, which has a basal pycnotic nucleus and lots of kind of secretory granules are there. These particular secretion granules are rich in protein substance. They picks up lot of stains there. So this particular staining will be there, which you are seeing here is going to be very, very bright. And this particular pycnotic element, once they burst into this particular duct system and they carried through this particular channel system and to the main duct, accessory duct, and to this particular ampulla vater to the second part of the duodenum. So this is the exocrine element or the exocrine unit of this particular pancreatic system. Now talking about the duct system and talking about this particular acini, so which has the serous acini. The cells of the serous acini has this kind of simple columnar kind of cells, or which is looking like a pyramidal or some kind of oval, that's we mentioned, and has this particular presence of this particular eosinophilia because of we mentioned that means it's a high in stains because of this presence of these protein particles which is rich in this particular degrading elements. We have these granules, we call them as zymogen granules, centriacinous cells, which is there for contractile reason, and this particular entire thing is responsible as functional units. And then once this particular things is secreted out of this, it drains into the duct system. Now out of this particular duct system, they are present as the intercalated ducts, interlobular duct, main or accessory duct. This is how these particular things are going. So this is the entire duct system of this particular pancreas which is looking like. Now this is a kind of schematic picture of this pancreatic tissue which you are looking at. Now first thing we have to focus here is that secretory element cell. These are the areas we are focusing here principally. So this is a pancreatic lobes which is split into the capsules. These are capsules which is present getting inside here and making some small pancreatic globules. Now these are the secretory cells or secretory acini which you mentioned here. Within this acini we can figure out this kind of thing which is a duct system which is present, just like the pancreatic duct which is present. Similar to that thing we have seen a parotid gland and other exocrine glands which is present in the salivary glands. Now this particular element along with this particular thing which is like the duct system and this particular secretory acini, we have this entire thing which is known as the exocrine component. Within this exocrine component we find an isolated area like this. So this like is a isolated cells or islet cells, or this is what we call them as islets of Langerhans. This element is different than that of this kind of cells. So there is no such similarity of the secretory acini or this duct with this kind of third element. So this is the third element which has to be the other element which is the endocrine element of the pancreas. So this element we call them as the islets of Langerhans, which is the endocrine element of the pancreas cells. So this particular area or this particular islets area of the Langerhans is restricted for the endocrine element. That means this particular pancreas has got endocrine functions and exocrine functions. These are the exocrine areas, and these are the small area or island which is capable of producing hormones or endocrine substances. So, this area we call them as islets of Langerhans because they are not present, they are scattered all over. Now, where predominantly we are going to see this kind of like a scattered cells is more we move to the tail of the pancreas, present in the central part, going through lot of things which is taking color, where you can find the area which is differently colored like this, and the cells also looks like different shaped of having different areas, polyhedral or circular or kind of like a different like oval shaped cells clustered together. They look morphologically and look wise also they are different kind of cells. So, these cells we call them as islets of Langerhans, which is endocrine cells. So, moving into the endocrine part. Now, once we see this particular endocrine parts of this pancreas, we are coming into the what are the different types of cluster cells. Now, if you zoom this particular cluster, that particular island, so if you just enlarge this particular cluster cells, which is present in this region, if you magnify this, we will see that the cells which is present in here are not similar. They are of different shapes, they are of different kind of structures are there. So, we are not going to elaborate this kind of cells which is present in here. We just focus in the islets of Langerhans and stop our deep digging into here. We just stay here about endocrine part, we call them as islets of Langerhans, that is a part, and this particular cluster cells is different from the acinus cells in the pancreas, and we stop at that. And then what we have to know, we have to do some special kind of stains, which I am saying, but you forget about this. Once you do a special kind of cells staining on this particular islet cells, there we are going to see or going to identify different morphological different cells. Now, for this we need to do a super zoom, that means we have to do an ultra fine microscopic zooming to stain this particular thing and see under microscope. So, there are some cells which is having amorphous cells, there are some cells which is polyhedral kind of cells, these kind of different types of cells are there. So, there are different cells, we call them A cell, B cell, C cell, D cell, there are different cells are there. Each of these different cells produces different kinds of endocrine substances. Say for example, this is the cluster thing which you are seeing here, this whole thing is that pancreatic tissues. So, these are the endocrine tissues which you have to find here, this is one endocrine island. Second, third, fourth, fifth, sixth. So, you have to look into it. Apparently, initially it looks like similar, then you can find some of the pockets which looks like pale relatively and looks like different kind of cells than that of rest of the endocrine elements. So, these are the kind of like areas which is endocrine capable areas, and rest areas which is exocrine capable areas. Exocrine means they are hormones, they are chemical substances, they are liberated into the duct system, they have the channels, they have these ducts, and these elements they do not have the ducts, they are liberated directly into the blood system, and through the blood it runs through different parts of the body and produces the functions. Now, this particular islets, if you zoom this, we see that this particular zooming areas and super high magnification, they are different kind of cells, and we have to stain it differently to identify different kind of cells which looks like this. Now, what we have to know, what are these kind of cells like A cells producing, B cells producing, C cells and D cells etc. producing. So, out here is a B cells which is a point of concern for us, which is the prime area which secretes the insulin, which is responsible for metabolic digestions of these glucose substances. A cells produces the glucagons which is counteracting with this insulin. Somatostatin, which is a growth hormone, as well as it is a stress hormone, and this particular element have a neurotic element as well. Now, these other elements which is the other things, vasoactive substance they are producing, serotonin they are producing, which is a vasoactive substances which is working on the capillaries and blood cells etc. So, these are the different types of cells in the islets of Langerhans, they are producing that. But whenever you are seeing this microanatomy, we do not ask you to identify it. We do not ask you to say that what kind of cells you are seeing. We do not ask you to narrate about this. We just only stop our discussion reaching at the islets of Langerhans, and we ask about what are the different areas of the islets of Langerhans cells which is present in here, like A, B, C, D, whatever it is, which is physiological things, and the functional hormones or the functional chemical substances coming from this particular pancreatic substance, what are they are producing, that is the physiological domain again. So, we do not talk about that much of things. So, to summarize the pancreas, we have this exocrine and endocrine. We have to identify which part is exocrine and which part is endocrine. Once you identify the exocrine part, then we are left with endocrine parts. Endocrine parts is identified by presence of cells which are not familiar or not similar that of the exocrine things. So, whenever you are seeing this particular pancreatic organ, you are going to see the plentifully the exocrine parts. So, predominantly the exocrine elements is there. So, this is a C which is produced by this exocrine pancreatic glands. That means, which is producing this particular chemical substance which is liberated through the duct system. Now, there are some pockets or some clustered area of the abnormal cells or kind of different kind of separate cells are there. Those things are floating on this particular ocean or this particular sea with different kinds of cells. We call them as islets of Langerhans. These islets of Langerhans are endocrine element or endocrine stations for the secretions of the endocrine hormones. And the endocrine hormones most notably is insulin and glucagon will be sticking to it, and somatostatin and other things which will be like discussed in physiology classes as well about this particular physiological functions, etc., etc. So, what are the functions of this particular pancreatic element, which is predominantly cells which is producing some kind of hormones which is serous in nature. They are proteolytic enzymes, the lipolytic enzymes, and as well as this particular glucolytic enzymes are there. They are breaking down this particular protein, glucose, and as well as the fat elements, and as well as these particular elements runs through the duct system, and that ducts, depending on how depth they are on, like lobar or interlobar, or how deep they are present, they are classified based on this. So, this is how this particular whole thing looks like, and this is how this particular entire thing should be looking like. In a normal zoom microscope, this is how we are going to see. Now, what you have to treat here, you have to just like see this particular element like this, and you have to find out which areas are not that similar or where we are going to see these islets of Langerhans, which is little bit different than that of that, right. So, this is what, whenever you are going to see this particular tissues in this particular histological pictures, we have to identify. So, let us move into this slide identifying points. No, that. পেয়েছিস, ফোকাস করতে পেরেছিস?
আছে তো তোদের টিভিএস গুলো সব হয়ে আচ্ছা অন্য কালারের চকগুলো দিও না রেড আর গ্রিন হ্যাঁ মাইকটা হ্যাঁ দাঁড়াও এখনো শুরু করিনি এঁকে দিয়ে কিছু বলছিস? Okay, good afternoon. So today's topic is tibia and patella. Okay. So first we will discuss patella, then tibia. Okay. So patella is a sesamoid bone. It is the largest sesamoid bone in our body. Okay, and it is ossified in the tendon of quadriceps femoris. Okay. So it is almost triangular. It is triangular. It has a base. Base is directed above and apex is directed below. Okay. So and it has two borders, medial border, lateral border, and two surfaces, anterior surface and posterior surface. Okay, and base is also sometimes known as superior border. Okay, so you can say it has three borders, medial border, lateral border and superior border. Okay, so now we will see the attachments of different borders and its articulation. Okay, in full extension of the knee, silent course. Okay, so in full extension of the knee, patella is freely floating. Okay, and during other positions, it comes in contact with the patellar articular surface of the femur. So this is right femur. This is right patella. Okay, it articulates with this patellar articular surface of the femur like this. Okay, different areas comes in contact with different parts. I will tell it. Okay, so first the articulation. How will you identify anterior and posterior surface? Posterior surface, there is a larger articular area. See here in this view, this is anterior view, here is the posterior view. In posterior view, you can see this large articular area is present, and near the apex there is a rough area. Here near the apex there is a rough area which is for attachment of the ligamentum patelli. Okay, ligamentum patelli is other end of the ligamentum patelli is attached to this tibial tuberosity. Okay, tibial tuberosity. Okay, now this is the this is posterior surface. Here is the anterior surface. Anterior surface is rough. Okay, and it has longitudinal ridges. Longitudinal ridges are due to ossification of fibers of the tendon of quadriceps femoris. Okay. This is the base. Here is the base. Base keeps attachment to 4 muscles. Okay. From anterior to posterior, these are anterior most is rectus femoris. Okay. Then in the same plane, 2 vastus, vastus medialis and vastus lateralis. And you can see vastus medialis is attached to the medial one-third of the base and it extends along the medial border of the patella and attached to the upper two-third of the medial border. Okay. But for vastus lateralis is attached to lateral two-third of the base and in the upper one-third of the lateral border of the patella. Okay. So this is attachment of vastus medialis and vastus lateralis. Okay. And posterior most there is attachment of vastus intermedius. These 4 muscles are together forming the quadriceps femoris. Okay. In which tendon the patella is formed. And this ligamentum patelli, it is also an extension of the tendon of the quadriceps femoris. Okay. Okay. So why attachment is like this? Because during extension of the knee, there is a natural tendency of the patella to displace laterally. Okay. So to prevent this displacement, there is this extension of the vastus medialis is extended more downward than the vastus lateralis, and also the attachment of vastus medialis on the femur, that is also extending more downward than the vastus lateralis. Okay. So this can come as I explained my question. Okay. There is natural tendency of displacement to the lateral side. To prevent this displacement, extension of muscle is like this. Okay. Attachment over the patella and attachment over the femur. Okay. Next, so base, attachment of base is covered. Now we go to the 2 borders, medial border and lateral border. Okay. Medial border, in the upper two-third there is attachment of the vastus medialis, and in the lower one-third medial patella retinaculum. Okay. That is extension of the vastus medialis. And in the lateral border, there will be attachment of vastus lateralis in the upper one-third and lateral patella retinaculum in the lower two-third. That is also extension of vastus lateralis. So attachment of 2 borders are covered, and at the rough area of the apex, there is attachment of the ligamentum patelli. Okay. So attachment of the apex is the ligamentum patelli. This is very frequently asked in your bones biology. Okay. Okay. Now we go to the posterior surface. Anterior surface is covered. It has longitudinal ridges due to ossification of fibers from the tendon of quadriceps femoris. Posterior surface has a rough area near the apex for attachment of ligamentum patelli, and upper part there is a large articular area. This articular area, it is divided by a vertical ridge into larger lateral part and smaller medial part. Okay. This ridge is dividing into larger lateral part and smaller medial part, and this smaller medial part, it is also divided into 2 parts. There is a very thin linear medial most part. Okay. And that comes in contact with the femur only in full flexion of the knee, and it comes in contact near the intercondylar notch. Okay. Intercondylar notch near the, in this medial condyle of the tibia, near the intercondylar notch, this medial most thin area. Okay. Now this smaller medial area and rest of the medial area and the lateral area, these two are divided by horizontal ridges into 3 parts. Okay. Upper 2, middle 2 and lower 2. Upper 2 comes in contact with the patellar articular surface of the femur in ordinary flexion. Okay. Middle 2 comes in contact in semiflexion, and the lower two, it comes in contact in ordinary extension, and the lower area in full flexion. And during the full extension, patella is free floating, okay. It does not come in contact with the femur in full extension, okay. So you have to remember during this movement, the parts are coming in contact with the femur, okay, understood. So patella articulates only with the femur, like this. This is the patellar articular surface of femur. It articulates with the articular surface on the posterior surface of the patella, okay. During different movements, different parts are coming in contact, okay. Okay, now how will you determine the side of the patella? That is very important. Apex is directed downward, okay, projectile apex is directed downward, base is upward, and this articular surface is posteriorly placed, okay. So above downward determined by apex, apex is downward, anterior posterior is determined by anterior rough surface, posteriorly smooth articular surface, okay, anterior posterior is done. Now medial and lateral, how will you determine? The posterior articular surface, it is divided by a vertical rib into larger lateral part and smaller medial part. So larger part will be directed to lateral side and smaller part is directed to medial side, okay. Another thing is, if you place the patella on a flat surface with apex away from you, okay, so it will tilt to its own size. In this case, this patella is tilting to right side, so it is right patella, okay. That's how you can also determine the side. So you hold it with your right hand, to which side it belongs, you hold it with the same hand, okay, and hold it through its apex like this, okay. So this will be the anatomical position of the patella. So you have understood anatomical position and side determination. Side determination is very important. It will be asked in your bones viva, okay. Above, below, apex is directed downward, above, below is done. Anterior, posterior, anterior rough surface, posterior smooth articular surface, anterior, posterior is done. Now medial and lateral, articular surface is divided into larger lateral part and smaller medial part, okay. So that's how you determine the side of the patella, okay, and hold it with the same hand to which side it belongs. Apex will be downward and hold it with your fingers, hold it near its apex, okay. So this will be the anatomical position of the patella. So this is right patella, it is tilting to the right side, and this is the left patella. You can see here, if you place the apex away from you, place on a flat surface, patella will tilt to its own side. So this is left patella, okay. So you have to hold it with your left hand like this. This is left patella, okay, understood? Okay. Now, what is the ossification? It ossifies from 2 to 3 centers, starts ossification from 2 to 3 centers, and that fuses with each other, okay. At about 2 to 3 years of age, it starts ossification, okay, patella. And as it is a sesamoid bone, so it does not have any blood supply. So in case of fracture of the patella, there is very less chance of fracture healing, okay. So there is some operation, it is fixed with nails, wires, okay. Okay, so patella is done. Now we will go to the tibia, okay. Tibia is the bone of the, see this is articulation between the tibia and the fibula. Two bones of the leg, two bones of the leg are the tibia and fibula, okay. Tibia is on the right side, tibia is on the medial side, and fibula is the lateral bone, okay. And tibia is a long bone, so it has a two ends and one shaft, upper end, lower end, one end, mid part is the shaft, okay. Upper end have two condyles, okay. These two are the condyles of the tibia. Here is the medial condyle Here is the lateral condyle, and in between the condyles there is intercondylar area. Okay. So these two condyles, they articulate with the condyles of the femur. Okay, intervening between the two bones lies the menisci, lateral and medial menisci, and these are forming the knee joint. Okay, condyles of femur and condyles of tibia together they are forming the knee joint. Okay. Okay. So this projecting part just below the condyles, this in the anterior aspect, this is known as tibial tuberosity. Okay, here the ligament, other end of the ligamentum patellis is attached over this tibial tuberosity. Okay, and this is the lower end. Lower end has a projecting part on the medial aspect, that is known as the medial malleolus of the tibia. Okay, and tibia and fibula, these two bones together is forming a concave surface, that is known as tibiofibular mortise. Okay, this tibiofibular mortise, it articulates with the upper surface of the talus to form the ankle joint, or it is ankle joint. It only articulates with the single bone of the foot, only articulates with talus. Okay, no, it does not articulate with any other tarsal bones. Okay, now attachment of the intercondylar area is very important. So these two are the condyles of the tibia. This is the medial condyle, here is the lateral condyle. Medial condyle is larger and oval in shape, and lateral condyle is smaller and circular in shape. And in between these two condyles, this rough area is known as the intercondylar area. In the middle part, it is narrow, and anterior and posteriorly it is expanding. In the middle part, there are intercondylar eminence. This projecting part, these are known as intercondylar eminence. Okay, anterior to it and posterior to it, some structures are attaching. These structures are important. Okay, in the anterior part of the intercondylar area, attachment of three structures from anterior to posterior. You can remember like this. Here, this is aim into medial meniscus. Okay, anterior only medial meniscus. Then there is C means cruciate ligament, anterior cruciate ligament. Then posterior to it will be the anterior end of the lateral meniscus. Okay, so this attachment is important. And posterior to it, in the posterior part of the intercondylar area, you can remember like this: Lucknow Medical College, LMC. So there is the posterior end of the lateral meniscus, then posterior end of medial meniscus, then posterior cruciate ligament. Okay, and these cruciate ligaments are named according to their attachment over the tibia, not according to their attachment in femur. Okay, other end is attached to the femur. So if it is attached to the anterior cruciate, it is anterior cruciate ligament, and if it is attached to the posterior part of tibia, it is posterior cruciate ligament. So the attachments are very important. Anteriorly, you can remember it, Medical College Lucknow, posteriorly Lucknow Medical College. Okay, understood? And this tibia and fibula, they are connected by a interosseous membrane. Okay, that is forming the middle tibiofibular joint. Now this now we will go to the shaft of the okay, another thing, there is attachment of some structure. This lateral condyle, anteriorly there is a smooth area, anterior part of this lateral condyle. It gives attachment to the iliotibial shaft. Here you can see, here anterior surface of the lateral condyle, there is attachment to the iliotibial tract. Okay, and posteriorly there is a facet for articulation with this fibula, okay, forming the superior tibiofibular joint, which is a plain type of synovial joint. Two surfaces are flat and articulating with each other, forming a synovial joint. Okay, so three tibiofibular joints are present. Superior tibiofibular joint is plain synovial joint. Intermediate tibiofibular joint is formed by the interosseous membrane connecting the two bones, tibia and fibula, okay, and that is a fibrous joint. And inferior tibiofibular joint, that is also a fibrous joint. In case of radia ulna, upper and lower was synovial, middle one was fibrous. But in this case, between tibia and fibula, upper one only synovial, middle and lower one both are fibrous. Okay, lower one is formed by the fibular notch of the tibia and the articular surface of fibula and connected by interosseous tibiofibular ligament here. Okay, in this here this triangular rough area, okay, it articulates with the fibula, okay, forming the inferior tibiofibular joint, and the two bones, two interosseous borders of these two bones are connected by interosseous membrane. Okay. Now, posteriorly, on the posterior surface of the lateral condyle, there is a groove for the popliteus muscle, okay, and in this area the capsular ligament of the knee joint is deficient. Okay, now medial condyle, on the anterior surface of the medial condyle there is attachment of semi-membranosus muscle. See here, there is attachment to semi-membranosus, and its attachment is also extending along a groove on the posterior surface of the medial condyle. Okay, so here will be the attachment of the semi-membranosus muscle. Now, attachment of the capsular ligament of knee joint is important. It is attached along the peripheral margins of the condyles of the tibia, okay, except it is deficient at two regions. In the posterior part of the intercondylar area, it is deficient due to presence of the popliteus tendons posteriorly over the posterior aspect of lateral condyle, and anteriorly the attachment extends downward up to the tibial tuberosity. Here you can see this dotted line is the attachment of the capsular ligament. It is going to be attached near this, extending downward towards the tubercle of tibia or tibial tuberosity, and posteriorly there is a deficient for the attachment for the passage of popliteus tendon. Okay, popliteus tendon is arising from the lateral condyle of the femur. Okay, in the femur, lower end of femur you have read. Okay. Now we are going to the, so upper end is covered. Okay, you have to know two condyles, anterior posterior surface, the attachment and the articulation, and intercondylar area you have to know. Okay. Now we are going to tibia. Shaft of the tibia, it is triangular in cross section. Okay. See here, this is triangular in cross section. Okay, and it has three borders and three surfaces. So borders are anterior border, medial border and lateral border. Okay, anterior border, here is the medial border and here is the lateral border. Okay, so anterior border, it is also known as seam border. Okay, seam border, seam guard pore na football khelar shomoy to prevent injury to this bone. This is subcutaneous border, seam border. Okay, and it is sinuous in course. That means slightly A-shaped, curved border. Okay, so it extends from this tibial tuberosity, extends downward along the anterior margin of the medial malleolus. Okay, so this is the extent of the anterior border from the tibial tuberosity up to the anterior margin of the medial malleolus. Next is the medial border. Medial border extends from below the medial condyle up to the posterior margin of this tibial malleolus or medial malleolus. Okay, from behind this medial condyle of tibia extending up to the posterior margin of the medial malleolus. Another is lateral border or interosseous border. It articulates, it extends from below this fibular facet, extends up to the posterior margin of the triangular rough area for attachment of the inferior tibiofibular ligament. Okay. So these are the extent of these three borders. Anterior border is subcutaneous. Okay, and medial border, medial border gives attachment to the deep fossa of the leg. Deep fossa of the leg is known as the fossa cruris. And lateral border, it is interosseous border. It gives attachment to the interosseous membrane connecting the two bones. Okay, so borders are covered. Now we will go to the surfaces. Okay, surfaces, there are three surfaces: medial surface, lateral surface and posterior surface. Medial surface between anterior border and medial border, lateral surface between anterior border and lateral border, and posterior surface between medial border and lateral border. Okay, so first we go discuss the medial surface. Medial surface is mostly subcutaneous. Okay, in the lower part, it is crossed by the great saphenous vein. Okay, in the lower part it is crossed by great saphenous vein, and in the upper part near the medial border there is insertion of three muscles. From anterior to posterior there is insertion of inverted hockey stick insertion of the sartorius. See here, inverted hockey stick insertion of sartorius, and the tendinosus. Okay, these three muscles are together known as gyropes. Okay, they are arising from three parts of the hip bone. One is sartorius is arising from the ilium, from the anterior superior iliac spine and the notch below it. Okay, inserting over the tibia. Then gracilis is arising from the anterior surface of the pubis. Okay, and some part extending into the inferior ramus of the pubis. And this semitendinosus, it is arising from the ischial tuberosity. So one is from ilium, one is from ischium, one is from pubis. Okay, and these three muscles together, when they are acting from their lower end, when they are acting from the tibia, they help in stabilization of the pelvis. That's why these three muscles are together called gyropes. Okay, gyropes muscle, it can come as a short note. Okay, you have to know the origin, insertion, nerve supply, action of these three muscles. You have to write down. Okay, so nerve supply is semitendinosus, tibial part of sciatic nerve, gracilis is obturator nerve, and this is branch from the femoral nerve. Okay, you have read during femoral triangle, and from the anterior division of femoral nerve, it is getting a supply, sartorius. Okay, and action from when they are acting from above, it causes flexion of both knee and hip. Okay, semitendinosus causing extension of hip but flexion of the knee, and gracilis is causing adduction and flexion, okay, of the hip. So these are the function of these three muscles. So these three are together called the gyropes. So medial surface is done. Now we'll go to the lateral surface. Lateral surface, in the upper two-third, it gives origin to the tibialis anterior muscle. Okay, only one muscle is attached. Tibialis anterior is attached in the upper two-third. Okay, understood? Now we go to the posterior surface, lies between the medial and lateral border. Posterior surface is divided by one very oblique ridge, which is extending downward and medially, and meeting the medial border at the junction of upper one-third and lower two-third. This ridge, this line is known as soleal line. Okay, this ridge, this is known as the soleal line. Soleal line, you have to ask, you will be asked to show it. Okay, soleal line. So just below the soleal line, there is attachment of the soleus muscle. See here, this is posterior view. Okay, this is soleal line. Just below the soleal line, here is attachment of the soleus muscle, and the triangular area just above the soleal line, here is insertion of the popliteus muscle. Okay, and in the upper part, here is extension of semimembranosus, insertion of semimembranosus. Now, upper triangular area, whole of the area is insertion of popliteus. Then just below it, there will be attachment of fascia covering the popliteus. Okay. Now, the lower larger area is divided by a vertical ridge into a medial and lateral part. Okay. So, medially there is attachment of flexor digitorum longus, and laterally there is attachment of tibialis posterior. Two muscles are attached. Okay. Medially flexor digitorum longus, and laterally there is tibialis posterior. Okay. Understood? Okay. Now you can see now, shaft is covered, 3 borders and its 3 surfaces and their attachments. Okay. Now we go to the lower end. Okay. Lower end, under surface of the lower end, it forms the tibiofibular mortise, articulates with the talus to form the ankle joint. Okay. And this is the tibial malleolus, tip of the malleolus. It gives attachment to tibial collateral ligament and sometimes deltoid ligament. Deltoid ligament is attached to this tip of the malleolus. Okay. Anterior surface and posterior surface are flat at the lower end of the tibia. Okay. Anterior surface, it is related to the following, some structures are related. The neurovascular bundles, they are entering into the, from the leg to the dorsum of the foot from this anterior surface. So, the structures from medial to lateral side, they are tibialis anterior muscle. Here one mnemonic is present. Okay. TB hole ami bhai noroker dak pai. Okay. So, TB লিখে দিচ্ছি। ওকে, টিবি হচ্ছে, টি হচ্ছে টিবিয়ালিস অ্যান্টেরিয়র। ওকে, হোলে হচ্ছে এই longus, this hallucis, hole হচ্ছে hallucis, artery and vein. Okay, anterior tibial artery along with its veni comitatus. Then neuroker, N হচ্ছে nerve, it represents nerve, anterior tibial nerve also known as deep peroneal nerve. Okay, dark হচ্ছে extensor digitorum longus, then power হচ্ছে peroneus tertius. Okay, so you can remember like this mnemonic. Anteriorly at the lower end of tibia, these structures are related from medial to lateral. Okay. And on the posterior aspect, these structures are related from medial to lateral. Okay. এইদিকে this mnemonic is টিকটিকির ডিম ভেঙে আমি ভাই নাকাল হলাম। Okay, so you can remember like this. this relation is important because you have to see the structures during your dissection of the leg. Okay, so টিকটিকির হচ্ছে tibial is posterior. Okay, dim is flexor digitorum longus. Then valgus together is posterior tibial artery along with its many committantes on the two sides of the artery. Then knuckle is tibial nerve. Okay, and holum is flexor hallucis longus. Okay, understood? So these are the anterior and posterior relations of the anterior posterior surface of the lower end of tibia. Okay, understood? Okay, and on this depression, okay, okay, on the posterior surface and the groove between the lower end and the medial malleolus, in this groove lies the tendon of the tibialis posterior. Okay, the medial most structure on the posterior surface. Okay, so these structures are clear. And on the medial side, and on the medial side of this lower end, here is one triangular rough area. Okay, it articulates with the lower end of fibula like this. Okay, and it is forming the inferior tibiofibular joint, and these two bones are here connected by inferior tibiofibular ligament. Okay, so this is a fibrous joint. Okay, so three tibiofibular joints are present: superior, middle and inferior. So these are the articulations of tibia. At the upper end articulates with femur, at the lower end articulates with the fibula and talus. Okay, so if you can be asked in your viva, what are the articulations of tibia? Okay, now we go to the, so attachments are clear for upper end, shaft and lower end. Now we go to the ossification. Okay, it is a long bone, so it has one primary center of ossification which appears near the middle of the shaft of the tibia, appears at about 7th week of intrauterine life. And there are two secondary centers, one for the upper end, one for the lower end. Secondary center for the upper end appears at birth or within 1 year of birth. Okay, and it fuses with the shaft at about 17-18 years. Okay, and for the lower end, the secondary center appears at about 2 to 3 years, and it ossifies with the shaft at about 15 to 16 years. Okay, so this is the ossification of tibia. Okay, now how will you determine the side determination and anatomical position? So these condyles of the tibia will be directed above, and also one thing is important, the secondary center for the upper end, the ossification extends towards the tibial tuberosity. Upper part of the tibial tuberosity ossifies from secondary center, and lower part from the primary center of the shaft. Okay, now how will you hold it in anatomical position? So these condyles will be directed above. This malleolus and this depressed area, this will be directed downward. So above and below is done. Now anterior and posterior, this tibial tuberosity is directed anteriorly. Okay, and medial and lateral you can determine this tibial malleolus or medial malleolus will be placed medially. Okay, so it is a tibia of left side. Okay, so if you place and hold it vertically with the same hand to which side it belongs, so it is a tibia of left side. If you hold it with left hand, all the points is correct. Okay, condyles will be above, malleolus will be downward, above and below is complete. Now anterior posterior you determine by this tibial tuberosity will be anterior. Okay, and the fibular notch, fibular articular surface, and that is placed laterally, and this tibial malleolus it will be placed medially. Okay, so medial lateral is done by this tibial malleolus and fibular articular surface, and anterior posterior by tibial tuberosities anterior. Okay, so this is tibia of left side, and here this is tibia of right side. Okay, see, malleolus is on the left side, medially, tibial tuberosity is anteriorly, condyles above. Okay, understood? Okay, so this is tibia of right side, and you hold it vertically like this. Okay, any queries? Okay, and you will be able to articulate with other bones. Next day there will be fibula. Okay, so first you hold the tibia in anatomical position. So if this is right sided tibia, okay, then you have to hold the fibula also in anatomical position. This is fibula. Length is not equal actually, bones of other bodies. This at the upper end of fibula there is a flat area. This flat area will articulate with this fibular articular area on the posterior inferolateral aspect of this lateral condyle of tibia, like this. Okay, and this here, this triangular flat area, it will articulate with this triangular depression at the lower end. Okay, so that will be the articulation between tibia and fibula. In this bone it has been articulated. This is tibia and fibula of left side. Okay, tibia and fibula of left side here. Understood? Okay, if you want to come and see here the bony structures, you can see here. Okay.